live?
It's live now. We can start.
Okay. Fine. Good afternoon, everyone, and welcome once again for the Development Studies lecture series at the Department of Humanities and Social Sciences, IIT Guwahati. We are indeed privileged to have with us Professor Rama Baru, and she will be speaking today on COVID-19 pandemic, the response of the private health sector, private healthcare to a medical emergency. Sorry. To begin with, it is again indeed nice to have our teachers with us. Last time we had Professor Mohan Rao speaking on population policy, the contemporary issues, and Professor Baru will be speaking on the response of the private sector. So to introduce Professor Baru briefly, Dr. Baru has been is a professor at the Center for Social Medicine and Community Health, Jawaharlal Nehru University, and she has taught number of courses for masters, MPhil, and the PhD programs at the center for the past 25 years. She is also an honorary fellow at the Institute of Chinese Study and an honorary professor at India Studies Center, Central China Normal University, Wuhan. And she largely works on a number of research areas, broadly in the areas of privatization of healthcare, social health inequalities, health policy, social determinants of health, and she has authored a number of books. Like one of her very important book has been on the private healthcare in India, social characteristics and trends, published by Sage in 1998. And she has also edited a number of books uh, uh, entitled School Health Services in India, the Social and Economic Context. And the work is on medical insurance schemes for the poor, who benefits. Her latest book is also a co-edited book with Dr. Madhurima Nandi, entitled Commercialization of Medical Care in China, The Changing Landscape, published by Routledge in 2020. Dr. Baru has been awarded a number of fellowships, and she's also on a number of committees of Government of India, at ICMR, at Department of Health Research, and at AIMS. Welcome once again, Dr. Baru, at the Department of HSS, and we are indeed happy to have you with us. So you can take around 40 minutes, and then we will open the lecture for discussion. Yeah. Thank you.
Thank you. Thank you very much. I'd like to thank the Department of Humanities at the IIT Guwahati, also the Health Studies Unit. And of course, it's always a pleasure when a former student invites you to give a lecture. Dr. Daksha Parmar, thank you so much for inviting me and sharing some of my thoughts on a very, very important topic, especially as many of us have been sort of riding this two very nasty waves of COVID. We have ourselves experienced COVID, or even if we haven't, we've had near and dear ones going through very difficult times. The lucky few who managed to stay at home and recover, but for the many who had to negotiate a hospital system, which one, the public sector, which was overburdened, and a private sector, which was actually playing truant at very many times. So I think for many of us, COVID-19 is a story that has touched our lives, and COVID-19 has had this the characteristic that it was not just the poor who were affected, but I think nobody was spared. The middle and the rich were also affected, and that gave it a very, very different aspect to this particular pandemic. I just want to begin with giving an outline of how I proceed to look at this particular topic that I am going to speak on. I am going to focus primarily on the private healthcare sector, but I'm not just going to look at provisioning, but I'm going to take a systemic view, which is to say, what was the role of the private sector and what was its behavior and response in a medical emergency? What were the capacities it had? What were the capacities that it was willing to lend? And what is it that they just did not really respond to in any significant way? And these various subsystems that I would like to cover through this 40 minutes lecture is one, provisioning, two, the financing aspect, that is what happened to the questions of payment in a country where a large percentage of the population is uninsured, and you have a targeted public insurance scheme, the PMJI, and then the provisioning, the financing, the drugs and technology, and the various equipments. And here I'm looking at the manner in which drugs were deployed in the private sector, and also irrational formulations being pushed, cocktails being pushed. And it was, in a sense, a heyday for the pharma sector. Then you have also the need for equipment, which came in the form of the PPEs, etc., which was another story of how we were totally unprepared for a pandemic, the needs of a pandemic. And in fact, the health workers who required these protective equipment were often not able to get access to it because we were actually depending on imports, and a large percentage of these imports came from China. So you have a situation where, and the last I want to talk about a little bit is research. And the reason I want to talk about this is the manner in which the apex bodies, the apex scientific bodies, especially the Indian Council of Medical Research, completely acquiesced to the political control and were not did not play the role that they should have, whether it was in the matter of data sharing, whether it was in the matter of even providing information regarding the pandemic, the issues around the standard treatment protocols, etc., etc. So there was an opacity that set in these institutions, which should have otherwise played a very important role in in some form of transparency and objectivity regarding the scientific evidence, even though the pandemic itself is, in my view, is about uncertainties. There was uncertainties in science. There was certainly uncertainties in the treatment and management procedures, as well as the uncertainty of human lives as they faced enormous disruption, both socially and economically, and of course exemplified by the plight of the migrants. And a public policy which just did not respond in the manner that it should have, except to centralize power and to, and I would go to the extent of saying also spreading false information. So, one of the important things I think about, and most of you would be aware, that the Indian health service system over the last 4-5 decades has been largely being dominated by the private sector, and the private sector itself, not just in provisioning, but in financing, both in terms of the entry of private insurance, but more importantly, the very high out of pocket expenditures that people have incurred are incurring for both outpatient and inpatient care, and the provisioning, structures of provisioning, and the data from the NSSO, which clearly tells us that the high reliance of people on the private for out of pocket, I mean, out of outpatient as well as inpatient services. So this has been the backdrop in which we see the pandemic set in. And when the pandemic sets in, the government moves very quickly and evokes all the possible acts to sort of centralize the command to, whether it was the disaster management, whether it was invoking of the Epidemics Act. So you used all the instruments, all the legal instruments to sort of take complete control of people's movements and coming up with policy decisions that were to affect many, many lives. And in this process, you have, in my view, the first lockdown becomes an important watershed. But even before the first lockdown, the indications as far as the first case that was detected end of January and through February, you had a rise in the number of cases in the country. But the kind of preparedness that you required in the health service system was something that was not happening. And in fact, there was very little effort, and whatever we have as reconstructions from that period clearly show you that there was very little preparedness. The responsibility, the onus of dealing with the fallout during the first wave, and I'll come to the second wave because I see it as actually exemplifying the fault lines and the kind of complete dereliction of policy between the two waves, as really producing the kind of effect we saw in all the subsystems of the health service system. But to come back to the first wave, the preparedness of governments to face and to plan, because if you're going to centralize the response, the responsibility of the central government would be also to plan for what kind of health services intervention you require. And by then, you had quite a bit of evidence from the rest of the world about how the pandemic actually moved. So, whether you looked at Western Europe or you looked at China or you looked at even the United States, you knew that there were these various forms of COVID 19, from the severe, moderate to the mild, and that it would require hospitalization. You, in fact, even had data to tell you that who would be the most vulnerable and what kind of health service response you required. Now, what is very, very important for us to understand is that in the absence of a regulated private sector, we have a private sector, a very large private sector, but we all know it's unregulated. When the when the demand for hospitalization came up, it became primarily the responsibility of the public sector. And in this process, also, the public sector had to be accountable. There was no choice. And we already knew the fault lines in the public sector. We knew the years of underfunding of the public sector, the human resource shortages, the shortages of diagnostic and other kinds of support equipment. We already knew that this was a flagging private sector. And in that, you had a tremendous amount of demand being put on it for when COVID cases started rising, and you required hospitals, hospital beds, etc. Even at this time, the response of the government was not to really put its spotlight on the private sector at all. In fact, there were some reports, early reports, I remember in April, when the demand was increasing. And in April, we had tracked some of this, and we found that the smaller and medium nursing homes were in fact closing down. And this was largely because they were worried about deaths happening in the private sector. But more importantly, whether in the public or the private sector, the required um, PPE kits were not available. There was a big problem that frontline health workers faced, both more nursing and also doctors. And in the public sector, there was a shortage of PPE kits. So you had almost a situation of complete breakdown and a complete, sort of uh, really a indifference to the people who were providing the care and also exposing patients to a lot of risk. So you also had a situation of a shortage of hospital beds. In this kind of a situation, we clearly had three options, and these are the three options that was exercised world over. One is that in a medical emergency, to nationalize the private sector. In fact, if you look at the case of Spain, the Spanish government nationalized their evoked emergency acts and emergency powers to nationalize their fairly large private sector and to bring it into the ambit of pooling resources with the public sector in order to have adequate beds and human resources to tackle the needs of the ongoing pandemic. And they were very clear in their mind that they would nationalize the private sector for a period, for a certain period, after which they would go back to the earlier arrangements. That was the option that we had. Of course, we did not exercise it. Once the pandemic really started, when the death started rising, there were some state governments that started what you would call as requisitioning the private sector. That is, they actually brought in the private sector, maybe not through a legal instrument, but certainly through orders of the local and the state governments saying that you will have to earmark your beds and you will have to treat COVID patients. Of course, these COVID patients were treated for a cost. It was not free treatment. A free treatment would have been only possible if you had nationalized the private sector. The last, it was almost a knee jerk, and if you like, a response, a late response to this whole question of a rogue private sector, as I would call it, because they were completely free to charge what they wanted. They were able to, make patients get drugs and supplies, and all the costing in many of these COVID related cases in these private hospitals were astronomical. And there are enough studies to tell you that people spend 3 lakhs, 5 lakhs, maybe much more, depending on the number of days that they had to be kept in the hospital. And the moment you had a ventilator support, or if you had to have other forms of oxygen support and oxygenated beds, the amount that you had to pay to these private hospitals was enormous. And it was at this point, through some legal intervention, through the intervention of the judiciary in specific locales, you had where the state governments responded by asking for price capping in the private sector. So you had these three instruments being deployed, but all whether it was the requisitioning or the price capping in the Indian situation actually happened after the event had already overtaken, which is the as I mentioned, and I'm very conscious of using this term, the rogue private sector, which actually did not have any compunctions in charging, overcharging. And this is not something new about the unregulated private sector in India. But even in the case of a medical emergency, one may argue that markets have no morality, but the moral dimension and the kind of social suffering that the pandemic produced was actually exploited by the private sector in order to increase its own profit margins. Now, one of the very interesting things about the behavior of the private sector, especially the provisioning sector, was that it is not a homogeneous sector at all. The small and medium nursing homes were more amenable to state control, and we saw some of these cases in, say, we saw it in Maharashtra, in Mumbai, we saw it even in Delhi. So the state could control the middle and small nursing homes to an extent, whether it was through price capping or requisitioning, etc. But the big player in the room was the corporate sector. And it's very, very interesting that by April, the hospital committees, both of the FICCI, ASOCHAM, and CII, actually came up with a statement saying that, because of COVID, our profit margins are going down. So we would want public subsidies to cover our gap. And because of COVID-19, our regular cases are falling. COVID-19 treatment is very, very expensive, and we will basically, our businesses will go bankrupt. So, I found that particular statement so inhuman and uncaring in a situation where people were dying and you were much more worried about your profit margins. So the term I would really use for this is it's a predatory private sector, which is constantly trying to wrest from the state various kinds of subsidies, which it has historically also, whether it is in form of concessional land, whether it is in the form of reduced duties for high-tech medical equipment, etc. So that is all history. But all this comes to roost when you see the pandemic. So you have a corporate sector which actually is using this as an opportunity to make more profits. You have a middle and small sector, some of them who just close down because they cannot afford to run their establishments, so they just close down. And you have a situation where the public sector is pretty much taking the entire burden of hospitalization due to COVID. Now, it's also the case that the when the second wave broke out, and I'm speaking specifically about Delhi, when the second wave broke out, there were very few beds in the public hospitals, and the demand for private care increased. And clearly, the upper middle class, the rich, were all trying to look for a bed in the corporate hospitals. And interestingly, that it was a situation in this country where money didn't assure you a bed, power didn't assure you a bed, and all the connections that you may have had with the political class didn't assure you a bed. So the hue and cry that you saw in the media, in the first wave, when the migrants were displaced, there was only a section of the media that really reported it with any sense of compassion and, the sense of what is morally incorrect. But when it came to the second wave, it was much, much more splashed in the media because it didn't just affect the low middle class anymore, but it actually affected the rich and the upper middle class, who suddenly found that they were out at sea as much as anybody else. So, what I'm trying to argue is that the corporate hospitals at that time were running full capacity with COVID patients. The charges were exorbitant. And in the context of a lack of a standard treatment protocol in the case of um, COVID, you found that the amount of money not just being made on beds, but on diagnostic procedures as well as medicines was enormous. And sometimes when you look at actually the billing, the drugs were procured by the family. As you know, we went into a situation of a black market and hoarding of drugs, and all kinds of irrational formulations were being tried out on people. And so there was this complete black hole as far as what were the treatment protocols being followed. So this was yet another opportunity for the pharma companies to make their millions. So you had hydroxychloroquine, then you had ICMR coming out and saying this is not required. So you had a whole lot of the use of indiscriminate use of steroids, the various zinc formulations that were sold for overcoming COVID. So you find that capital made full use of this pandemic with very little or no interference from the government. So you had everything going, and to top it all, the oxygen shortage, as you all know very well, became uh, was the worst case scenario that you could ever see, and the way it was politicized, etc. Now, the other aspect, which when I spoke about the paying for this hospitalization, paying even for home care, the kind of disruptions that people's lives underwent by losing jobs, etc., etc., meant a huge financial burden on families, on caregivers, and if you had more than one or two people who had to be hospitalized, it really sunk families into indebtedness. Now, large part of the payment for an uninsured middle uh, class came from out-of-pocket expenditures. Those who had private insurance, even there, the way the private insurance companies manipulated the manner in which they did their reimbursements has been something that is being written about now. The third pillar, of course, is the Ayushman Bharat or the PMJAY. And I was just looking at some data based on an RTI that was filed on for PMJY reimbursements. Firstly, that the due to COVID, the routine care and the routine packages that people were resorting to under PMJY had gone down drastically right from March to June. It's also very, very important for us to understand that the uptake of uh, PMJY for treatment of COVID was extremely low. So let's look at two large states and two of the less developed states, UP and Bihar. And this is based on an RTI to the Ayushman Bharat Trust. And you find that in Bihar, only 19 claims were made for treatment of COVID, that is hospitalization. And in UP, it was 875. And in Jharkhand, it was 1,419. So this figure varies quite a bit. But the point that I want to make is that actually having Ayushman Bharat for hospital coverage did not ensure even those who are enrolled with the Ayushman Bharat got uh, at least near full compensation, which is what it is supposed to do for the COVID-19 pandemic. Now, therefore, what we are really seeing is that this has been a period where people have actually spent out of pocket to cover their costs. And therefore, the picture of the private and the targeted public insurance scheme is actually showing you that even in the time of an emergency, when you would expect the public, the state to respond and to make sure that everyone gets access to healthcare, this is not happening. And it is also the case that when you have a pandemic like this, you would think it would be a historical opportunity for the government to actually revamp its public sector, to um, bring in policies that would regulate the private sector and learn from the failures of this whole COVID-19 pandemic. But if subsequently you look at a lot of the government documents, it's business as usual. The Niti Aayog document on commercialization and privatization of the health sector is the roadmap ahead. There is very little extra investment being made, which we needed significant amount of increase in our public spending. That has not happened. And the private sector continues to be exploitative, but unaccountable. So, in this kind of a scenario, you really, really wonder what kind of politics is being played out. And this is the last bit I want to cover, which is to say that this is not just about the health service system. It is about the a political class that was completely, um, disinterested, and I've used the term, it amounts to social murder, and I'm very consciously using it because this is the term that Engels uses in his essay on the conditions of working class in England. And he actually says that the kind of high mortality you see among the working class is actually a result of a policy which the state allowed, whereby people were living in terrible conditions. They did not have access to health services, and this actually makes the state culpable for the situation that people were in. So, to come back to this idea of a social murder, and I use it very consciously, is that you have basically acquiesced all responsibility. You have said it is now an individual responsibility, and therefore that there is very little accountability of the state to its people. Yes, there was a lot of public anger against the government, and there was a lot of anger against not being able to get access to services. And this anger was across classes. It did get a certain visibility. Some sections of the media did pick it up, but that did not seem to do really have the kind of effect that one would have thought it would have. There was also international media scrutiny, and of course we always say that that is something we can ignore, that they're all anti-Indian anyway. So to come back to this question of the manner in which the private sector has behaved, is something that is actually extremely shocking. It is a certain, uh, I would call it a daylight robbery. I would call it a situation where you can do anything you like and get away with it. But this seems to be a reflection of the larger political climate in which we live. And therefore, I really worry about what is going to be in the future. The last point I want to really make and very seriously make is when you have independent agencies, scientific bodies like the Indian Council of Medical Research, and in the Niti Aayog, the person who leads the health unit, both the heads of these particular bodies are former doctors of the All India Institute of Medical Sciences, of which we are all very proud. But these are the very two heads of these institutions, one Dr. Vinod Paul and Dr. Balram Bhargav, who have completely become supplicants to the present political dispensation, that they couldn't speak up on at various points, whether it was about the vaccine, whether it was about pushing the Covaxin for emergency use, whether it was about the seropositivity surveys that were done. There was very little transparency. And even about the need, what is the quantum of PPE kits we would require to service the protection of our health workers. None of this planning was in place. Instead, in March, after the first wave, we declared that COVID has left us, and we were, banging talis and clapping for our health workers. I mean, it is really criminal negligence of an order which I don't think we have seen in modern times after in post-independent India. And it is really, truly shocking that when the leadership of public sector agencies, scientific agencies, don't uh, exercise their autonomy, don't exercise their freedoms to speak about what is correct, what they know, and what they don't know, I think we are in for a lot of trouble in this country. I think I'll stop here and maybe we can take questions. Thank you.
Yeah, thank you very much, Professor Baru, for this very critical lecture on the way in which the private health sector has responded to this crisis. So I now open the discussion for question answers. If there are any questions, kindly raise your hand and then please introduce yourself. And Vikas and Rubul, if there are any questions in the YouTube, please let me know.
Okay, ma'am.
Yes, Professor Rao. Professor Mohan Rao.
Has he unmuted?
No. Yeah.
Yeah, my question is, what kind of investments have come into the corporate sector from, say, the World Bank or venture capital, et cetera, over the last 5 years?
Actually, it's last 5, maybe even last 10 years, the equity and venture capital has invested in many of these corporate hospitals. Not all, and it varies. There has also been some amount of partnerships with global hospital firms. They're in. So what they've basically done is they've diversified, right, into many smaller units, and some of these have partnered with uh, different countries. Some from Singapore and other countries where they have tried to build partnerships. So it could be in the area of medical and nursing education, it could be for diagnostics. So you have a lot of partnerships that have been formed, but the role of venture and equity capital has been quite significant in the hospital sector. And so, you have these kinds of partnerships that have come in.
Thank you.
Okay, any other questions? So before we get more questions, Professor Baru, I had a questions like, despite this crisis and despite the fact that the pandemic had been so devastating, uh, the response of the government has been to privatize more, like the way in which district hospitals has been now been made open for investment of the private capital. Like, how do we understand this phenomena? That is, like, I understand that it's a larger political economy in which we are, the times that we are living in, but rather than say investing or strengthening the public systems, the most functional or the most, the district hospital, which has been one of the most important lifeline, has been now opened up for, say, the private capital to invest. So can you throw some light on that?
Yeah, I think there is a systemic approach to the manner in which this government, its first term and its second term, they have been very clear that it is going to be commercialization. So there is going to be more of private investment in medical education, and that's where the issue of the district hospital also comes up. So you see, it all begins with saying that we need to expand the production of doctors. So in order to do that, every district will have a medical college, which I think is preposterous. But every district will have a medical college, and that medical college, in fact, if you read the Niti Aayog document, it's very clearly spelled out. And it will have investments from abroad. It will facilitate investments which are domestic, and it will make sure that the district hospital also is opened up for control by the so-called public-private partnership model of the medical college, and that the the hospital will be supported by the revenue generated. That is, it will become a revenue generating unit in order to compensate also the public spending on the government. So whatever proportion the government puts in will also be reimbursed through the revenue generating model. So in fact, what you're saying is you will have more user fees, you will have more charging for diagnostic facilities, etc., etc. So this plan was there by the end of the first term. And in fact, they have done it in consultation with the BMGF, the KPMG, and the Boston Consulting Group. So these are the advisors to this particular government. So, you have this kind of an approach which has already been put in place. Now, COVID comes, and you would think COVID would kind of turn the apple cart, but it doesn't, because the interests and the direction of this particular government is for greater corporatization. There's no doubt about it. And therefore, you will find that he will do a number of populist programs. He'll spend money on populist programs. Those are the vote earners. But in terms of a systemic change to the financing of the health services, that is not happening. So you have a odd mixture of corporatism with populism, and that seems to be the model of governance for the future. So, our old ideas of what would be a universal public healthcare system, which in a sense we saw in the 60s and 70s of, welfare states and welfareism of both Western Europe and East Asia, whether you look at Japan or Korea. That kind of a model is not the model that this government is following at all. And it does not wish to follow. It's not as if it is blind, it is very clear what it wants ahead. Look at the way we've, where is it? You can argue then in the same vein that actually COVID-19 pandemic gives us an opportunity to revisit investments in R&D and public research and production of drugs. It just didn't happen. You gave it to a Bharat Biotech, which is a private lab, for the production of Covaxin. So, all I'm trying to say is that it's very, very clear. The path that they have drawn ahead is one of greater corporatism, but then you will have a whole plethora of populist programs, which are meant for appeasement and for winning elections, nothing else.
Okay, thank you. Anyone else? Students? Faculty colleagues?
Daksha, I pasted one in the messages, which is from
Okay,
UK.
okay, yeah. This is Amitabh. Just a minute. Given the situation, Dr. Baru, the question is, given the situation of corporate Raj in private healthcare market in India, what is your opinion on private sector regulation frameworks currently available in the country? How can Clinical Establishment Act be further improvised in the context of the pandemic? You need to unmute, Professor Baru.
Sorry. Okay. It's a very, very interesting question, and there is a very good document that the Health System Transformation Platform, HSTP, if you Google and go there, just 2 weeks back, they had a discussion on a document that they have prepared on looking at the various regulations that are available for the private sector, not just in provisioning, but in also other subsystems of the health service system. But to come back to your question of clinical establishments bill, as you know, it has been majorly fought over and contested, and also the role of civil society organizations has been extremely important in getting this bill passed. But ultimately, the uptake of Clinical Establishments Act has been a state subject, and there are several states which have not taken it up. A few metro cities have, in states, have tried to implement it. But one of the important things about the Clinical Establishment Act is that it covers largely only the middle and the large and the smaller nursing homes. It does not cover the corporate hospitals at all. And whether in the time post-COVID, whether we will have a strengthening of the Clinical Establishments Act, I'm not so sure, because you see there are too many divisions within the private sector, and the role of the IMA has always been, I would say, rather myopic, because they should use these instruments to improve the functioning of the private sector. But very often different constituencies sort of water these efforts down. I think the Clinical Establishments Act itself has been diluted quite a bit. But having said that, I think it would still be useful to carry this forward. Now, there were other forms of regulation, accreditation, but this became primarily the interest for the corporate hospitals because for medical tourism, you needed global accreditation. And it made sense for them to get accreditation, not just from a national body, but from international organizations. So, you have all these rather quasi, not so well developed, maybe well developed, but with very poor implementing structures. So this is a very, very important area. I think if we really want to take some of these ideas forward, even from the civil society, and here I don't mean just NGOs, but even the academia, this is an area I think we need to look forward to working on to see what kinds of, uh, given the dynamics that exist within the private sector, what are the spaces that it creates in order to push for regulation of various kinds. This would apply to diagnostics. So you have a number of acts which don't speak to each other. And therefore, it's an extremely fractured landscape of regulation. And that is why you're not able to really pin the problem down in a sense. I hope that answers your question.
Okay, any other questions? Students?
Hi, ma'am. I'm Vikas. I'm a PhD student at the HSS department. You are talking about the vaccination and Bharat Biotechs. So I wanted to know from you what is happening with this vaccination in India and at the international level, if we are talking about vaccine politics, and also how it can affect this, as we see this recent private players has been taken into consideration for this vaccination, the entire vaccination process. So and also this what is happening with this accreditation of vaccination in other countries, like a talk is going with USA whether this Covishield and all. So where we are heading with this entire vaccination program in India, and what's the role of private sector in it?
Well, right from the beginning, the entire production of vaccines has been in the private sector. So whether you look at the production of Covishield, which was part of the uh, AstraZeneca uh, partnership, and the Serum Institute producing it, it was in the private sector. The public sector was absent anyway, right from the beginning. There were people from the People's Health Movement and other scientists who argued that this was a moment when you could actually revive the production of vaccines in partnership with existing public institutions. But that didn't happen again. And Bharat Biotech was chosen to produce what was called, you see, there's a lot of vaccine nationalism and imaging and the brand building that went on, right? So you said you had a made in India vaccine, and that vaccine was produced by the private. We were anyway a large player in the global market for vaccine production, not about the COVID vaccine, but if you look at all the childhood immunization vaccines, etc., India is the leader, followed by China and Russia in a sense. So what you really find in the COVID-19 vaccine story is that you used the capacities of the Indian private sector to give a brand of a made in India vaccine, which is the Covaxin. Now, I have been privy to the kind of pressures that were put on ICMR itself to approve the uh, early use of Covaxin. And I can tell you that while several scientists may not have come out openly, but within the ICMR body itself, there was a lot of concern about using it when the full trial data was not put out. But this is why I had, in the end of my lecture, spoken about the inability of the ICMR to stand up as an independent body which would, take a position which was scientifically and ethically correct. But having said that, so Covaxin becomes the brand name, right? But what is also interesting is we still haven't got approval from the WHO about the Covaxin and the portability of Covaxin. The rest of it is, of course, a lot of vaccine politics. It is about, Pfizer, Moderna versus Covishield and Covaxin. And in fact, more importantly, the Chinese vaccines and the Russian Sputnik. So it's a very interesting area to sort of look at how the ideas of vaccine diplomacy, vaccine nationalism, and vaccine politics, in a sense, speak to each other. And that we have, the US has exercised vaccine nationalism also because it procured, pre-ordered, pre-booked their more than what they actually required for vaccinating their populations. They did not really feed into the common portal that was set up by WHO, which meant that you actually would have, you would not hoard vaccines, but that you would put it in a pool where it could be distributed across countries. And those who needed it the most should get the but it's in fact become reverse, because if you look at Africa, they don't have their own production capacity, and they have very little being supplied to them, right? So then you find that that is yet another aspect of what happened in India. So you had Covishield, you had given emergency authorization for Covaxin, but you were also doing vaccine Moitri. I mean, and what were you doing? You were trying to bolster your image. That is, the prime minister was trying to bolster his image in the global arena, saying, "Oh wow, look at India." And we suddenly went into this period where we didn't have vaccines. The demand for vaccination was there, the supply wasn't there. I mean, we were all victims of it, right? We wanted to go and get our first shot of whether it was Covishield or Covaxin, and they said sorry. And the second wave was particularly the case when people were queuing up for vaccines in a city like Mumbai, but they were told, sorry, we don't have stock. So right through this COVID pandemic, our priorities have seemed to have been to, self-aggrandizement rather than really be worried about any planning. The planning process was just absent. And the so-called groups that were constituted to manage this problem, whether it was the vaccine or the hospitalization or the oxygen supply, they were always reactive. They weren't proactive at all. And it's not that we had any dearth of data. It is not that we didn't have any modelers modeling and predicting. We had the data, we had everything, but we just didn't act. We just let things slide. But if you're interested in this, maybe you can get my email from Daksha. I have a whole lot of papers on this vaccine diplomacy and politics and the whole global policy on vaccines and what has happened. So I can share that with you.
Thank you, ma'am. Sure. Thank you.
Professor Baru, there is another question in the message box. It's by Keti Nandu. He writes, okay, I'm not able to identify. Ma'am, is there important positive stories from private sector? For an example, it is the private sector which helped for an early identification of Nipah in Kerala during COVID period.
Okay, I did get into the Kerala story. I think that in Kerala they managed much better. Firstly, if you look at the Kerala data, the hospitalization rates were quite low. And that's also because the public health system was fairly aggressive with surveillance and monitoring. And you're absolutely right that the Nipah virus had taught them many, many important lessons of how to do it. And it is also the case that the government itself uh, requisitioned the private sector in a way which I think they built on their earlier experience with Nipah, and they were able to requisition at least sections of their private sector fairly effectively. So yes, and don't forget, the whole decentralization approach meant that the local panchayats played a very important role in all of this. So I wouldn't say that the private sector is better regulated in Kerala, but it was certainly a better example of how you could requisition the private sector to work for a public health emergency. And I think they had already sort of worked that out for Nipah. And a lot of the COVID work actually was piggybacking on the earlier Nipah experience. But this is not the case. I mean, Kerala is in this situation is a complete outlier because it is not the case in the rest of the country. In fact, when Delhi government tried requisitioning the private sector, it was a complete mess. They just didn't know how to do it. In the middle of a public health emergency, you can't be pleading with the private sector to come and work with you.
Okay, any other questions? Meaning I just to yeah, Abhilasha. Abhilasha, why don't you introduce yourself? And if you have a camera, can you put on your camera?
Uh, Hello, ma'am. Thank you for your lecture. I'm Abhilasha. I'm a PhD student here. Sorry, I am not in a position to switch on my camera. Uh, but I had a question, ma'am. The other day, I was talking to a person who faced a lot of issues during the lockdown period. He belonged to probably a lower middle class family, and his business was down. And he after that he actually got symptoms of depression. So lockdown initially in the first phase dealt a huge blow on the lives of the daily wage workers, and then in the second wave it dealt a blow on the lives of the lower middle class and middle class people, and they got to know that okay, the government is actually not investing much on employment, neither is it giving them any other subsidies or any other sort of financial help. So I would like to know your views on, was that kind of strict lockdown really necessary for our condition?
I think there was quite a bit of debate even during the first wave, that did you really need a complete lockdown, or could we have done things a little differently? Because you see, what the complete lockdown did is it completely immobilized our movements, right? And in the process, what you did is you brought the economy to a pretty much a standstill. And during that period, it dislocated people considerably. The second wave actually happened even though you had indications that a Delta virus was already in circulation, especially in parts of North India and Maharashtra, and that it was an extremely contagious variant, and that it would produce disease which was pretty lethal. But during this period, you weren't really looking at the health services at all. And you again came down with a lockdown. Now, the point really is that there have been other countries that have tried other ways of handling it. For example, Sweden went through what we would call as a partial lockdown. They didn't completely lock down. And I don't, well, you can argue that they are not densely populated countries, that, that their settlement patterns are different, their levels of development are different, etc., etc. But, I somewhere feel that this lockdown idea of completely controlling people's lives somehow, I mean, this is my view, resonated with the politics of the present government. That you had a natural, you had a moment for a natural experiment where you could completely, uh, instill fear and lock people's lives down. But you also know that it has had a very, very bad effect on the economy. It has produced very high levels of unemployment, and like you rightly said, it has really affected uh, not just the physical but the economic and the mental health of people, right? So this kind of disruption that it produced, and one can, I mean, I would like to ask the question, okay, you did that kind of a draconian lockdown in the first round, but when you lifted it, did you have all the systems in place to ensure that people could return to some semblance of normalcy with some assurances? That didn't happen. Then you had a second wave, which was really devastating. And, especially young people working in the services sector, running small businesses, they've been completely decimated. So, what does that mean for a country where we are still a young country? What does that mean to for them in terms of hopes for the future, hopes for building newer relationships? It becomes extremely difficult. And in the education sector, it's been a disaster. Here we are on Zoom all the time. How do you do PhD on Zoom? I still don't understand. How can you and mind you, the many people in the Ministry of Education love this. Okay, now we don't have students, they won't gather, they won't create trouble. यही अच्छा है, online में सब कुछ कर दो. So I mean, I really think technology has been used in this whole process of lockdowns, where individual freedoms and other things have been deeply, deeply affected. I feel very strongly about that, and I'm hoping that all of us will get into an offline mode soon with the due precautions that's required.
Thank you.
Yeah, thank you. Yes, Vasudhara.
Hi, hi, Professor Baru. I was just wondering, since you're also working with China, so I was wondering if you could speak a little bit about how China has dealt with the pandemic since it started there, and we all know that the situation is quite bad in China, and at one point we stopped hearing about COVID in China. So I was wondering if you could tell us a little bit more about how the pandemic was dealt with there.
Yeah, I think the difference between the Chinese outbreak of the pandemic and the Indian is that um, it was really during the Spring Festival. So there's a lot of people movement during that. But the moment they picked up cases, and the epicenter was Wuhan, they did a draconian lockdown. In fact, it's interesting that while there is a lot of China bashing after the outbreak of COVID, if you look at the experiences that are replicated across the world are variations of the Chinese lockdown. So this idea of a lockdown itself comes from the Chinese experience of handling their first bout. The experiences of people in the period of lockdown is very similar to what we are discussing here. So it is not as if, yes, they are a single party rule, that there is control over people's lives. All that may be true, but that didn't prevent people from expressing what they were feeling. Their health services were much better. They were able to provide the required hospitalization, etc. But the day to day lives of people, atomized through this process of the lockdown, did lead to a lot of anguish, anger, and tremendous uh, emotional and mental stress. So there is this diary which is written by this woman and which has now become a bestseller called the Fang Fang Diaries. And if you read that, it's a daily account of what happened during the lockdown in Wuhan. So she actually records what was happening in the medical care, what was happening to elderly people, how were rations delivered, how you couldn't meet your parents, whole range of things. So it did produce enormous amount of stress. Then they managed to control it. They, of course, went on an aggressive vaccination drive, etc. But they have had resurgence of COVID. What is the extent? And it's no longer, about Wuhan, but it is about other provinces as well. So COVID is in a sense here to stay, but how you manage COVID is an important question. And I think this idea of a draconian lockdown did come into the global discourse from China. There's just no two way about it. I think it is only the Swedes who tried to experiment otherwise. And they had their own debates around whether you should have a full lockdown, a partial lockdown, or did the lockdown help at all? Those kinds of questions were being debated in many public health journals. The Americans didn't do a lockdown. Yeah, but look at the kind of deaths they saw. And there, in a sense, the Indian and the US story is quite an interesting comparison of a aggressive private sector, largely a private sector, and a public sector which was taking the entire burden of COVID care in many of the inner cities, a disproportionate deaths of blacks and Hispanics compared to whites, poor whites dying in inner cities. So you saw all the uh, reflections of inequalities played out in the American context as much as you saw it in our context. So I think in that sense, the scenario across the world of this language of the lockdown really, in my view, is a Chinese import into the global discourse on.
Thanks.
Yeah, thank you. Any other questions? Okay, if not, then I take Basundra or Vikas or Rubul. Any other questions on YouTube?
Ma'am, I think Alakriti has a question.
Okay, Alakriti, I can't see your hand raised in the Teams. Alakriti, you want to introduce yourself and then ask your question?
Hello, ma'am.
Yeah.
Hello, ma'am.
Yes, please go ahead.
Ah, good evening, ma'am. Thank you so much for the wonderful speech. So, ma'am, I just wanted to know, like, how has the private sector handled the chronic diseases, given the fact that COVID-19 is affecting especially people who are with chronic existing condition like diabetes or other heart diseases?
Actually, the COVID-19 pandemic has been a great disruptor for routine care. And as you know, all chronic diseases, and some of them are syndemic conditions. That means you just don't have diabetes, but you may have, heart-related and other problems that come together that require regular monitoring. So, you go through your blood tests regularly, you get your medication, you get it recalibrated. All these, and cancers was another very major area of, people's treatment getting disrupted. Mental illnesses, you couldn't see your psychiatrist, you couldn't go for medication. So, a lot of this went online, but we know that for many of these conditions, you can't go online. You need to be examined, you need to go through tests. So I think this, but and that's why I was saying that there is some data on how even in the Ayushman Bharat, the regular packages for all these conditions that you're talking about actually suffered, in the sense that people suffered not being able to access care. But equally important, I think, is that the COVID-19 in some of these larger hospitals, actually they did not take on cases of routine care for many of these chronic conditions. A lot of operations were postponed, a lot of regularly slated surgeries requiring immediate attention were postponed. So you had that kind of suffering that was compounded by COVID-19. And there was also this fear among people not to seek care. So there was one aspect of, you know, doctors telling you don't come, but there was also the other side of you saying, I don't want to enter a hospital and get COVID. So I think this has been a period of enormous disruption in regular care, in routine care. And it is not just for NCDs, it is for also, you know, your eyes, your teeth, your range of other conditions, especially dentistry suffered hugely.
MCH.
MC, of course, immunizations weren't happening. Routine immunizations got affected. Yes.
1.2 million women seeking abortions couldn't access it.
Okay, thank you, Professor Baru. Professor Rao, you want to add something?
No, I just wanted to add to Rama's list of services that were not available. I've seen the figure of 1.2 million abortions seekers not getting services.
Thank you. Any other questions? If not, then I take this opportunity to thank Professor Baru for discussing a wide range of issues with the private health sector, be it in industry as well as research, and the way in which government institutions have also functioned, and also throwing light on the vaccination aspect. I would really thank all the students and the doctoral scholars and my colleagues who have attended this lecture, and the participants in the YouTube live session. And I also take this opportunity to thank Vikas, who made the poster, and our doctoral scholar, and Rubul for all the technical help. Thank you, Vasundhara, as well. Yeah, thank you, Professor Baru. Thank you.
Thank you very much, Daksha, and to your colleagues. And I hope we'll remain in touch. And if some of your students want access to some of the material, please give them my email ID and they can write to me.
Sure.
Thank you, ma'am. Thank you.
Thank you.
Thank you. Bye-bye.
Bye-bye.